Hello, welcome to OncoLife interview session. It's my pleasure to introduce our guest today, Dr. Gribben from the Cancer Institute in London and the past president of the European Hematology Association. Thank you so much for joining us today, Dr. Gribben.
Thank you very much. My pleasure to be here.
Well, today we will take a closer look at the clinical and systematic landscape of CAR T-cell therapy, life-saving treatment that's redefining cancer care, especially for patients with the aggressive and the treatment-resistant blood cancer. We will discuss the real-world challenge, the progress made, and the future step needed to double access this therapy by 2030. Could we start with some information about your background and your professional journey?
Sure. So I'm currently a professor of medical oncology at Bart's Cancer Institute at Bart's in the London School of Medicine, University of London. My background historically has been as someone with a major interest in immunology approaches to treat cancer, and a lot of my research focused on why it is that our own immune system isn't able to tackle cancer and ways in which we are able to overcome that to use patients' own immune system to tackle their cancer. An approach that, in my experience, patients find very attractive, to be able to think that we'd be able to do this in this way. And of course, a lot of my research is focused on what are the reasons why patients' own immune system doesn't see the cancer and why the cancer is invisible to our own immune system. And of course, CAR T cells have emerged as a way now of being able to overcome that barrier and have the immune system able to recognize people's own cancer in situations where, of course, chemotherapy have no longer worked.
As a both clinician and researcher, can you give us a broad overview of the treatment potential of the CAR T-cell therapy and share your perspective on its future role in oncology?
Absolutely. So, of course, as you already alluded to at the moment, we have CAR T-cell products approved for some hematologic malignancies, some subtypes of lymphoma, acute lymphoblastic leukemia. There's a whole bunch of research work going on in other fields to try to get CAR T-cells to work not only in hematologic malignancies, but also in other cancers. And perhaps in a moment, we'll come back and chat about that. There's also some work being done in autoimmune diseases, that is, for diseases where cancer is not the focus of the treatment. But just to put it in perspective, what this is about collecting patients' own T cells. That's the T cell of the CAR T. That's done by what we call apheresis. The patients go on a machine, their T cells are collected from their blood. Those T cells are then sent off to the laboratory where a new gene is inserted into the T cells. And that gene is what we call a chimeric receptor. And it's a chimeric antigen receptor, which is where the CAR part of the CAR T cells come from. And what that chimeric antigen receptor is one half of it inside the cell is the signal that tells the T cell to switch on and become active. And the outside part is an antibody that sticks the T cell onto the lymphoma cells, in this case. And therefore, we have a way in which the T cells become attached and become activated by lymphoma and start the process off whereby there's an immunological reaction which is able to kill the T cells. So this chimeric antigen receptor overcomes the difficulty we have of the cancer cells being invisible to a patient's own immune system. And by putting this new gene into their T cell, we are able to have those immune cells recognize and very effectively kill cancer cells. Because they do it in a very different way than chemotherapy, these CAR T cells can be very effective in those patients in whom chemotherapy has already failed. That is, those patients who've either had more than 2 lines of therapy before, or whose disease is what we call primary refractory to chemotherapy. And by using a mechanism of killing the cell that is separate from chemotherapy, we're able to overcome that barrier and find that many of these patients are then again able to respond very well to the immunotherapy in a way that they could not respond to the chemotherapy. And this then has really curative potential for a group of patients who were, before this therapy became available, really had very, very poor outcome indeed.
Despite CAR T cell therapy's curative potential, access remains limited. From your perspective, what are the most significant systematic barriers to accessing this life-saving therapy?
You are absolutely correct. Our data suggests right now that probably even in centres and even in areas where the CAR T cell is available and reimbursed, perhaps only 2 out of every 10 patients that could be eligible for this approach are getting this product. There's a whole variety of different barriers. One is the fact that these patients are not always the centre which can deliver the CAR T cells. So the physicians, the oncologists who are looking after these patients have to be able to recognize quickly who are those patients who might be eligible for the approach. And they then have to be referred into the centres that offer the CAR T cell treatment. These patients often, particularly those with refractory disease, often have a very aggressive disease, and time is of the essence here to be able to recognize who these patients are, have that referral done quickly. Often these patients live a long way away from where the CAR T cell is being delivered, so there's logistical issues in terms of getting the patients from where they live to where the treatment can be offered. There are, of course, reimbursement issues, depending on what type of insurance somebody has, whether this type of therapy is covered or not. And of course, in Europe, where I live and where I work, there are whole countries in where this product is not yet even reimbursed at all, and is not available. So there's multiple barriers that get in the way of people being able to be offered this potentially life-saving treatment. And part of this whole initiative we're planning to do and talk about is how we can work as a community to think about how we can overcome all the barriers that get in the way of patients being able to be offered this treatment to increase the number of patients who will be eligible to receive this.
You have been involved in both clinical care and policy decision. How can treatment centers and health authorities work together more effectively to speed up patient referrals and access to CAR T cell therapy?
So you are absolutely correct. When I was the president of the European Hematology Association, and I chaired the European Affairs Committee as part of that role, it was part of my job to be looking to advocate for increased access to our patients with hematologic disorders to all sorts of treatments, including, of course, CAR T. That involved working with the European Medicines Association, EMA, the equivalent for the FDA in America, as well as dealing with the country's national bodies that are responsible for dealing with whether or not treatments become available and whether they're reimbursed, and also with the HTAs, the health technology assessments that go on to look to see what's the benefit that can be seen in terms of making sure that the therapy represents good value for money. Now, of course, in the US, part of this assessment happens, of course, in dealing with people's own insurance companies. But in Europe, of course, with much more socialized medicine, much of this is done at a national level. And ensuring that we have ready access is part of what we call the European Beating Cancer Plan, which the European Union is looking to implement to try to see how we can improve the outcomes for patients suffering from cancer all across Europe and decrease many of the disparities that occur from the more, the richer countries in Western Europe compared to many of the countries, particularly in Central and Eastern Europe, where access is much, much more limited. So it's all about advocating to say why CAR T therapy may be expensive, but of course it still represents very good value for money because of its curative potential, and because, of course, it represents a one-off treatment with potential cure, meaning that the patient doesn't then have to have repeated courses of subsequent therapy, with the impact that has not just on the finances, but also, of course, on the quality of life of our patients and their families. So a lot of that work happens as part of assessing both the results from clinical trials as well as what we call real world evidence. What happens to, and what are the costs involved, and what are the savings that can be made to our healthcare systems in terms of offering the best and most effective treatment as early as we can in the therapy, so that patients are not wasting their time, their effort, their money on having less effective therapies, which may seem cheaper at the time, but which over the long run are going to actually increase the cost of care, as well as potentially closing off the avenue to potentially curative therapies later on down the line.
What is the potential for existing CAR T cell therapy into earlier treatment line or new indication? And how should health system prepare for this evolution?
Very good question, because of course, as your question suggests, it's a constantly moving field. The first thing is, of course, is that we are already seeing that CAR T therapy is moving earlier and earlier in its line of therapy. In lymphoma, it was initially approved for people who had failed multiple prior lines of therapy. Now it's approved in what we call second line for people who either are primary refractory or who relapse soon after their second line therapy. In multiple myeloma, originally it was approved for patients who'd received 4 or more lines of therapy. Now the results of clinical trials have shown that we see much better efficacy when it's offered to patients much earlier in their disease journey, and we now have approvals to treat patients in second line. Now, this is important for a number of reasons. Firstly, the results in second line therapy are much, much better than when we offer the same therapy in third or fourth line, so more patients can potentially be cured. The second thing is that by giving a one-off therapy with potential cure, we do not have to give multiple lines of therapy with all the costs that therapy involves. So by giving the CAR T cell therapy as early as we can in the journey, we increase the efficacy and overall decrease the cost, as well as improving the quality of life for our patients by omitting chemotherapy, which is not going to work well for them.
Real-world evidence is critical for the health technology assessment. Are European systems doing enough to collect and act upon the real-world data on CAR T outcomes and the cost effectiveness?
That's a really good question that you ask in terms of how well and we collect real-world data. What the real-world data, of course, is not patients not treated in clinical trials, but people treated in practice outside of clinical trials, and whether or not the data that happens to those patients reproduces or perhaps even potentially exceeds those seen within clinical trials. It's often the case also that real-world data includes patients who would not have been eligible for the clinical trials in the first place, and it's very important that we see that we're not offering therapy to patients that potentially could cause harm, or using very expensive therapies that are not going to be very efficacious. So in the United States, where the data is collected by BMTR, and also in Europe, where this data is collected in the registries that we have within the European Bone Marrow Transplant Registry. We have programs that EBMT and EHA have set up, looking to make sure that we collect all the data that we need. I think we can all look to a country like France, where not only have they done a very good job of making CAR T cells more accessible, and where they have a high uptake, but also where they've done a really good job of having all the centers produce the data And they have this program called Descartes, where they are actually are looking very much to collect that data, publish the data, and make sure it becomes available. And I think it's incumbent on everyone who's delivering CAR-T to make sure that the data we collect on all of our patients continues to be registered. All of the patients who undergo CAR-T give consent for their data to be registered within these registries. And for us to, as a community, work both at the national, international, and global level to make sure that we can all learn as much as possible from each other and from each other's patients to advance that field forward.
The vision set ambitious goal to double the access by 2030. In your view, what are the top 2 levers policymakers must act in the next 2 years to make this reality?
Well, you're absolutely right. It's our goal to increase the access, and many people have criticized us for being perhaps not ambitious enough by saying we only want to double the access. But of course, certainly within Europe particularly, we're starting from quite a low point. I've already told you that some countries have no access whatsoever. We know that even where we do have access, it's fully reimbursed, and we're not relying on third-party payers to pay, that we know that not enough patients are being referred. So I think number 1 issue is to continue to advocate for access for our patients. And the number 2 issue is to continue to educate the community to recognize the patients for whom CAR T-cell therapy can be effective, and to ensure that those patients are referred very quickly into the treatment centers to make sure that we can potentially offer the largest number of these patients that therapy. And I think if we can do those first 2 steps, we're very much on the way to being able to double our goal, and then we can have more ambitious goals in terms of really looking to increase so that all potentially eligible patients are able to receive this therapy in the future.
Well, thank you so much. I have finished my questions. I don't know, is there anything else you would like to add or highlight from this discussion?
No, I think we've managed to kind of, just looking through, I think we've managed to cover pretty much everything that we want to, and I hope you turn this into something useful for your followers.
Thank you very much.
Great, good to talk to you.